Nice. Okay. Tracy, can you hear me?
Yeah, I can hear you.
Cool. Your name is yeah, printing this out was, yeah. Sometimes it worked and sometimes it didn't. So kind of the way it goes. More and more. Not here. More Victoria, more Victoria, more Victoria. Mark again. Oh, that was stuck to the back. Okay. Oops. Wrong class. Okay. Yep, wrong class. Wrong class. Oh, here we go. I have another copy of this. I've got the grade on it. For some reason, 2 copies got printed out, but yeah. Your grade is, and Damon's not here. Crumbs. Okay. All right. And then, oh, there you are. There you are. Did you see the blonde head? I think you're Morgan, but you're not. Yeah, well, when you have your head turned, because it's a nice, beautiful tuft of blonde hair. Okay. That's okay. Or that. Oh, it wasn't open. Good. Let's work on that together. Okay. All right. Allison. Okay, Allison. Yeah, Kate's not here. Anna's not here. He is here. Dang, that looks good. What is that? I know it's a salad. What kind of salad? Like I said, it looks. Morche. And this is another class. Yes. You should have grades in for them. Oh, shoot. So did you guys get my email? So we had every time This happens with a network outage. Grades go missing. This morning in my other class, I had 7 students come up and say, we didn't have a grade for this and this, and I know I put grades in this weekend. They got dumped. So if you had anything that get dumped, Haley had, what, 2 things that got dumped? So Haley had things that got dumped, things from a long time ago that got dumped. So if you see anything that looks hinky, they probably got dumped. Because I graded them this weekend. And I entered them. Okay. So I need to find those and re-enter. This is a drag. So, okay. All right, just a word on the dosage calculations. Flow rates are pretty clearly causing some of you fits. I don't have time really to do much of that tonight. Maybe I'll do something to walk you through a few of these because some of you are dividing when you should be multiplying. Here's the rule. Take the units and work backwards. If you take the units and work backwards, that'll help you set the equation up usually. Some of you, your units don't make any sense because you're working it out and then you're putting the units on there. But according to the way you've done the equation, it should be micrograms squared or something like that. So when you have units, the units are your friends. Use the units to kind of help you work backwards and then come to an answer. Okay, so this is our last day. I've been trying to do some podcasting and stuff to try and get you more stuff and what have you. I hope you've been doing those. The exam, I'm in the middle of writing the exam. It's, let's see, I'm about halfway through. So, and then don't forget, we'll have a shindig Wednesday. And then after today, I know you guys probably have clinicals early tomorrow, but I'm gonna hang here. If you guys have anything you wanna ask me about, I'll be here. So we can talk about whatever you want, okay? And I'm here tomorrow. I won't be here in the early morning because Chuck White and I pound the pavement in the morning and then, but I'll be here the rest of the day. So if you wanna come talk to me or text me or send me an email saying, help, I don't understand this or whatever, please feel free. And then Wednesday, I'll be here all day Wednesday too. So not an issue. All right. Please get out the local anesthetic handout. All right. Local anesthetics are virtually all of them inhibit voltage-gated sodium channels. Now, these drugs typically are kind of lipophilic. So you can give them IV, but you usually don't because they will cross the blood-brain barrier and then they can cause all kinds of mischief. When they cross the blood-brain barrier, they can be really suppressive. Lidocaine, of course, is an antiarrhythmic. So you never give lidocaine IV. It'll cause arrhythmias. So these really are well designed for local anesthesia. Now there's 2 types that are those that have an ester bond and those that have an amide bond. Now I know I'm pulling you all the way back to chemistry. Some of you probably are trying to forget chemistry as fast as you can. Please don't just yet. So an ester bond, well, here, I'll do it up here so the folks on Zoom can see. So an ester bond has this configuration here. This part here is an ester. Oh, crumbs. Well, the people on Zoom can see just fine. Good night. Who ate all the chalk? This part here is the ester. Lots of things in your body have esters. So esters are really common. And you have lots of enzymes that degrade esters. They add a water, cross this bond, and oh, there we go. If you add a water across this bond, you're going to get a, who's that? This can ionize, so it's a carboxylic acid. Now, Natalie, maybe if I draw this, because I'm under physiologic pH, this will ionize, and you'll have this. That looks more familiar, maybe, when it's ionized. That's a carboxylic acid. This over here that's your alcohol. So these two moieties are very water soluble. Esters are not nearly as water soluble. So these enzymes that break them down are esterases. You have tons of esterases everywhere, lots of them. So esters are going to be broken down pretty quickly. They're not going to have a very long half-life unless you put them somewhere where there aren't many esters. And one place where there aren't many esterases are the central nervous system. So these work really well for spinals. They live a very long time in the spinal cord, in the spinal column. So these are used for things like epidurals and injections into the upper spinal cord for people with really bad types of headaches or things like that. People with sciatica, things like that. These are really good for that. So those are the esters. That's the top group of those. Let's look at those very quickly. Benzocaine you only use topically. Now this is used in over-the-counter products for sunburn. So Lanacaine, Dermaplast, some sunburn lotions will have benzocaine in it. Reason you only use it topically, it will tend to cause methemoglobinemia. Paige, what's methemoglobinemia? Andrea, do you know? Sorry? Something with a hemoglobin. That's correct. Well, you're all right. It's something you think about. You take the iron in the hemoglobin and you convert it from an iron 2 to an iron 3. And it doesn't work as an iron 3 anymore. That's methemoglobin. Methemoglobin. Remember in micro, your plates, some bacteria turn the plates green. They converted the hemoglobin to methemoglobin. That's the green color. So you now have blood like Mr. Spock's. So you don't ever use this. You don't ever inject this. You only use it topically. Procaine, which is marketed as Novocaine. So that product is hydrolyzed to p-aminobenzoic acid. Lots of people have allergies to p-aminobenzoic acid. So allergies to procaine are really common. So procaine is never used anymore. This one, in fact, is on there largely for historic purposes. In fact, you could just write in that little box, never used. Never used. Rarely used, if ever. You may even write in there, I will never use this. You probably won't. Chloroprocaine. Chloroprocaine is used in kids. Very well tolerated in kids. So this gets used a lot in children for topical things. For example, Timmy slides into home base and didn't see that rock on the playground and it slices up his shin. So Timmy needs stitches. You're going to put stitches in Timmy without any topical? Well, then it takes 5 people, 4 to hold, 1 to do the stitches. So a better idea is after you clean it would be to just give him some chloroprocaine. Then you can put in the stitches. And you can see it lasts more than long enough. And if it's with epinephrine, what does epinephrine do? Why do you inject it with epinephrine? Yes, but why?
Is it because it constricts the blood vessels?
Grace is right. You ever in here, Grace? She said that over. Causes vasoconstriction. Because it causes vasoconstriction, its diffusion rate is much slower. So when you get an injection for dental work, that's usually lidocaine. That lidocaine will usually have epinephrine in it. Now, if you have a heart condition, you'll tell the dentist, and the dentist will give you lidocaine without epinephrine, which means he or she will have to dose you more often because it'll diffuse more. So that's the one that's used for kids. The other that's used a lot for spinal is tetracaine. Tetracaine. And that is very long lasting. Yes, believe it or not, cocaine is used as a topical anesthetic. It's used in head and neck surgery. Cocaine is not only an anesthetic, it's also a vasoconstrictor. So you don't have to use it with epinephrine. That's why it's used. It's used as cocaine hydrochloride. Usually used on mucous membranes. And then Duvocaine, that's only topical as well. It's too toxic for systemic use. Now let's talk about the amides. So if you have this bond, this is an amide. Those are hydrolyzed by amidases, but amidases are not nearly as numerous in your body or as widespread as are the esterases. So these will be longer lasting. Now let's add a water, cross this bond. What you gonna get? What do you think? Who's that? If it ionizes, that's a, you need a driver's license to drive it. Car, carboxylic acid. Carboxylic acid. Over here, you're going to get and what is this? Nitrogens are called semi-M, amides, amines, right, amines. This is an amine because you have the two here, it's a primary amine. Primary amines. These are more soluble than the amides. I know it's painful to review chemistry. You're all trying to blot that class out of your memory, but you will need to use a little chemistry as a nurse, believe it or not. Okay, let's talk about the amides. So definitely the big gun in this group is lidocaine. Lidocaine is definitely the most heavily used topical around there. It's used topically, it's used sub-Q for pain. When I had my fingernail removed for the biopsy, they use lidocaine. It's very, very, very widely used. It's very versatile, extremely well tolerated unless it gets into the bloodstream in high concentration. Because it's very lipophilic, it can cross the blood-brain barrier. When you use it topically, that virtually never happens. Because when it gets into the blood is loaded with amidases in some places and it gets broken down. But it can cause seizures, but that's only if it builds up. Typically, this drug is really, really well tolerated. Very widely used, and it comes in all these different trade names: xylocaine, solarcaine. Hey, solarcaine. Some of you may have used solarcaine for sunburns. That's over the counter. So there's even topical versions that are over the counter. Blah, 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 so on and so forth. Doesn't last very long with epinephrine, lasts 4 hours. This gets used a lot also for dental work as well. Articaine. Articaine is really not very long-lived. So it's good for really fast procedures. This gets used a lot for dentistry in Europe. They use it in the United Kingdom, for example, dentistry, wisdom tooth extraction. They'll use this and they keep having to inject you. Bupivacaine is typically used for spinals. Levobupivacaine. Bupivacaine comes as a racemic mixture of 2 chiral molecules. Levobupivacaine is the leftward rotating, it's the R stereoisomer of bupivacaine. That's got a slightly longer half-life. Etidocaine is used for dental procedures, but it causes increased bleeding. Used sometimes during labor and delivery, but again, that increased bleeding is a big issue. So this one, that's something if you do find yourself in a procedure where this is being used, watch bleeding for sure. Mepivacaine, this would be the honorable mention one for dentists. Lidocaine and mepivacaine, probably 2 of the most widely used, especially in dentistry. Prilocaine is only used topically. So if a dentist, for example, wants to, let's say you had an implant in a tooth, the dentist wants to shave it down because you're having occlusion problems, they may spread some of this on your gum and then carve it down. Ropivacaine is definitely the safest of all the anesthetics. Pramoxine you get over the counter. Way too toxic to use systemically, only use topically. Then you have drugs that are combined. I will let you look at those. And these get used for burns, for wound repair, for stitching, so on and so forth. All right. What are some of the adverse effects of these? The biggie, of course, will be CNS effects. This is going to be more the case with spinals. You usually won't get this if, say, you're giving someone a local to do some stitches or to debride a wound or something like that. This is usually the case with epidurals and spinal administration. Headache, restlessness, anxiety, dizziness, tremors, blurred vision, backache, usually with spinal. Cardiovascular, peripheral vasodilation, that's going to be dose dependent. So that's not all that common. Myocardial depression, that's dose dependent, and you really have to give someone quite a bit for this to be much of an issue. And then arrhythmias, and then blood pressure changes. Respiratory arrest, again, that's usually an overdose. Nausea and vomiting, that's usually only the case in elderly people or children. Loss of skin integrity, that's usually you've given someone a sub-Q shot, and you've probably seen this done. The area gets really swollen when you put it in, and then after a while, as the drug starts to be absorbed, it starts to go down. Have you seen this before? Yes? No? No? You will. You will. In fact, many of you will probably do it before you graduate from here. Some people who can't move, that might compromise their skin integrity. Before you inject this, make sure there aren't any sores or wounds or something like that. Also, you might want to take your gloved hand and just kind of ply the skin, make sure the skin integrity is good. Okay. Things to be concerned about. So if you co-administer epinephrine with bupivacaine and lidocaine, you have significant reduction of absorption. That's not the case for these two, etidocaine and bupivacaine. So etidocaine and bupivacaine are often given without any epinephrine. Lidocaine, however, the delay of absorption is substantial with epinephrine. So your esters are subject to extensive hydrolysis by this enzyme plasma cholinesterase, a ubiquitous enzyme. The other name of it is butyryl cholinesterase. If you see that name, butyryl cholinesterase, that's what it's referring to, plasma cholinesterase. Hydrolysis is quite rapid. The metabolites are very soluble. They're excreted in the urine. That's not the case with cocaine. Cocaine is metabolized in the liver. And we talked about benzocaine, procaine already. Now, there are patients who have this condition called pseudocholinesterase deficiency. They lack plasma cholinesterase. These folks are at risk for toxicity. In fact, we're going to talk about this when we get to anesthesia. These folks are at risk for a condition called malignant hyperthermia. If a patient, after being given anesthesia, their temperature starts to climb, the antidote is dantrolene, the muscle relaxant dantrolene. You always have dantrolene on hand, always. In fact, have dantrolene nearby. Know where it is. Look around the room and say, here, dantrolene, here, boy, here, boy. And when you find it, If that temperature starts to rise, they need antrolene ASAP, because malignant hypothermia is nothing to mess with. Amides are metabolized by the liver, and then their metabolites are excreted in urine. And we talked about prilocaine. It makes derivatives that are toxic. So the rate of metabolism, you can see lidocaine is metabolized pretty quickly. Bupivacaine is metabolized the least fast. And then duration of action. So lidocaine is moderate acting, long acting butetracaine, bupivacaine, and nitidicaine. And then doses will cause varying degrees of vasodilation. Lidocaine is the most vasodilating. That's why it's often given with epinephrine. Blah, 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 so on and so forth. Those are the anesthetics. Local anesthetics, by and large, very well tolerated, very useful. You'll use them extensively in your practice, and those are the drugs. Are there any questions on the topical anesthetics? After surgery, it's very common for someone to be filled with local anesthesia at the area where they've had their surgery. For example, I had a hernia as a baby, so I was at risk for another hernia. And when I lived in the United Kingdom, it popped. And so I had a second hernia surgery. And the surgeon, when I woke up from that awful anesthesia, oh my word, he said, you've got 12 hours of local, but after those 12 hours, you're going to hurt. And boy, howdy, was he right. So that's very common. Some patients, the local, they may not tolerate it well. It's usually the anesthesia that they'll react to more than the local. Some of them will itch. It'll itch, which they shouldn't scratch because they've just had surgery there. You're not supposed to scratch it. If you do post-op nursing, one of the first questions you ask a post-op patient is what? What's your pain? What's your pain? And let me just warn you right now, if you have someone who abuses painkillers, you're not going to be able to give them enough painkillers to deal with their pain. So just be aware of that. But when you give them their pain, just if they have some local irritation, it might be due to the local anesthetic. In most cases, it's not an issue, but sometimes it is. Grace, do you have any questions about local anesthetics? No? Okay.
I do not. No, sorry.
You're not? Okay. Okay. Let's now go to generals. Some of you may become nurse anesthetists, so these types of drugs will be your bread and butter. So a general anesthesia provides a reversible state that includes these 5 things. You have a loss of consciousness, lack of recall, relief of pain, immobility, and an autonomic and sensory block. That's so when you cut into them, they don't move, something like that. Now, of these, definitely the one that's used the most in hospitals today is propofol, by far. Propofol is extremely well tolerated. Extremely well tolerated, largely because it has a really short half-life. So the infusion must be constant. There's a other drug called fospropofol. Fospropofol has been removed from the market. It causes terrible pruritus when you wake up, so it's been discontinued. Now, these others have their uses. They're definitely not used as much as propofol. So if your surgery is short, your surgeon will usually prefer, or your anesthesiologist will prefer propofol because they'll wake up relatively quickly. It's used for colonoscopies, it's used for EGDs, it's used for lots and lots and lots of different things. Very well tolerated. Diprivan is the name of this. These drugs are GABAergic drugs. They potentiate GABA activity. Now remember, pull your heads back to last year in A&P. GABA is an inhibitory neurotransmitter in the central nervous system. The GABA receptor is a ligand-gated channel. It's a chloride channel. It opens, chloride rushes into the cell, and it hyperpolarizes the cell. Is that kicking some rust loose? Yes? No? I'm getting a lot of blank stares. I'm getting a few of you going, yeah, I'm getting others going. Okay, trust me. GABA is an inhibitory neurotransmitter. If you increase GABA activity, you downregulate neural activity in the brain. That's how these work. So, surprise, surprise, one of them is a barbiturate. What do barbiturates do? They potentiate the GABA-A receptor. So the one that's used typically in your surgical anesthetics is this methohexatol. Methohexatol. There was another one called thiopental that was used. Thiopental has been discontinued. You can't buy it anymore. Propofol, as you can see, works very quickly. This one takes a little bit longer to work. Now, when I had my hernia surgery, what they used on me was this stuff, midazolam. Now, this author classified it under a non-barbiturate. I'm sorry, midazolam is a barbiturate. It binds to the GABA-A receptor at exactly the same place as the other barbiturate. It's a barbiturate. This stuff, trade name Versed, when you wake up from this stuff, you will feel drunk. I'm not kidding. You will get up and the whole world will be spinning, and it will take you a day or two to get over it. Propofol, you get over it really fast. This stuff, oh doggy, you'll be drunk for a while. So if you're doing step down or something like that post-op, they're on an outpatient thing, but they've had this stuff, don't let them get up by themselves. You help them up, because they're going to get up and the room's going to spin, and they might go straight down. Also, when they walk out, if someone comes to get them, which someone should come to get them, you should not release them by themselves. Make sure that person knows this person is at fall risk, even if they're young, and particularly if they're older. So they should take the arm or stand behind them and grab their shoulders, whatever it takes to prevent falls. All right. Ketamine. Ketamine has the advantage of also being a really good muscle relaxant. So ketamine is used at times if you want both anesthetic and muscle relaxant. Now, the problem with ketamine is this. Ketamine is now a drug of abuse. So if someone is hooked on ketamine and you give them ketamine for anesthesia, that spells disaster, doesn't it? So ketamine is used, but you have to make sure that someone's not an abuser of ketamine. Droperidol was taken off the market, and then last year it appeared on the market again. It's now being used again. Droperidol was taken off because there were reports that it caused arrhythmias, but every anesthesiologist who used it says if you use it too long, yeah, but you only use it for a short period of time. If you use it for a short period of time, that never happens. So droperidol is back, and this one is for short use only. All right, so those are your anesthetics that are not gases. Not gases. Again, these drugs are very, very lipid soluble. They penetrate the blood-brain barrier quickly, and they tend to work fast. Now let's go to the gases. Now, the gases, if you look at the stages of anesthesia, you have the stage where you go numb, then you have a stage where you get kind of excited, and you're trying to get people into the surgical anesthesia stage. You go to medullary paralysis, you've gone too far. You need to not pass go, collect $200. You need to go back here. So you're using something for induction, where you take them to stage 3. You want to try to bypass stage 2 as much as possible. Induction, sometimes you need something that works really fast. That's the beauty of propofol. Propofol is its own induction mechanism. Then maintenance, where you maintain them in stage 3. And then recovery, you withdraw the anesthetic and the patient wakes up, regains consciousness, and you're supposed to talk to them and ask them questions about, what day is it? What's your birthday? How's your mother? Whatever. By the way, did you guys all call your mom yesterday? Good job. Pat yourselves on the back. Without our mothers, we wouldn't be here, would we? There's this trend now. People want to call mothers birthing persons. Oh, balderdash. No, she's a mother. Use the term. Say it. Mother, you coward. Good gosh. Well, I'm offended. Well, guess what? I don't care. I just, some things are just stupid, and that's one of them. All right, so the gases are used for induction. You don't use gases for maintenance. Can you guess why? Why don't you use gases for maintenance? Yes, they'd be a pain in the butt, yeah. They dry, they can irritate the esophagus. So you use gases short term. You use gases to induce them. You can use gases with these, because notice these take longer to work. These tend to work lickety split. And so nitrous oxide is used a lot in dentistry, particularly for children. It's quite safe for children. It's used also in Great Britain for childbirth. Mothers will take a puff, a hit of, they call it gas and air. It's a mixture of nitrous oxide and air. It takes the edge off the whole birthing process, which is, yeah, that's laughing gas. It's used mainly in dentistry. I'm not aware of, I think midwives might use it. And they use gas and air. Okay, so they are using it here. Well, did she have a midwife for her? Okay, then there are some hospitals that are using it. Okay, I wasn't aware. That this wasn't at Allegiance, I take it. Mercy and Detroit and Muskegon. Okay, so, all right, so some are using it. The problem with using that is if you, usually when you're giving birth, you want to have your wits about you. So when the doc says push, you push. This stuff kind of puts you on the ceiling. And yeah, anyway. So these three gases here, of these three, the safest is this one here, sevoflurane. Yeah, Haley? Yeah, it doesn't work in some people. It's rare. Yeah, I think it's one in, I was reading this the other day. It's like 1 in 500 people or 1 in 400 people. Yeah, it doesn't work. And yeah, and that tendency is inherited. Yeah, so yeah. So these are used for induction. And again, the one that is used the most, the one that's the safest is sevoflurane. These others will have a tendency to irritate the esophagus. This one doesn't. Yeah, Abby? Both typically. And so you usually mix it with just a topical, you paint onto the, or kids usually have a fear of needles. So you may give them this and then you soak a little tissue in lidocaine or something like that. You then paint it on the gum. Then you give the shot of lidocaine, they don't feel it. And then with the laughing gas, they're really feeling great. So that's used a lot in pediatric dentistry and also for people who have an innate fear of needles. It's used sometimes too for vaccination. Peds will use it. They'll give the kid a hit of laughing gas and then they'll rub the arm with a bit after they disinfect the arm. They'll put some lidocaine on it so they don't feel the initial jab. And then when they get the jab, the kid's kind of giggling. And then you bandage the arm and then they're, yeah, it's terrific. So, yeah. So that's used also in peds and tends to work. Okay, so the issues with these are as follows. Barbiturates don't have any analgesic effect. When the patient comes out, they must have some sort of postoperative analgesic. And usually, if you're a post-op nurse, you will have medication at the ready for patients who have pain. These, again, they can cause bradycardia and hypotension. You get decreased GI activity, which if they've had bowel surgery, the bowel is going to have decreased activity anyway. So if they have resection or hernia repair or appendicitis or you name it. Nausea and vomiting also relatively common, and it's more common in women and in the elderly. Midazolam, bad hangover effects. Hangover is pretty appropriate for that. So someone, if you're counseling someone after surgery, they've had midazolam, emphasize to them they should not drive the rest of that day. They should also not drive the day after because it takes a while to recover. Seriously, that's particularly the case if they're older. Droperidol, there's the risk of QT prolongation. This drug is great because it has an anti-emetic effect that reduces post-surgical nausea and vomiting. That's why anesthesiologists like it so much. So you can combine this, particularly at the end of the procedure, and you don't get the vomiting, particularly if someone has a history of not tolerating anesthesia very well. Ketamine. The issue with ketamine is if people have cardiac conditions, this is sympathomimetic, so it can up blood pressure. It can also cause hallucinations and dreams and stuff like that. Can cause psychotic episodes. So if someone has any sort of psychiatric issue, no ketamine. Propofol. Some people, when it goes in, say that it burns. Every time I've gotten propofol, it's felt cold to me. So go figure. This will be very individual, but the biggie with this one is that you do get a reduced heart rate and hypotension. You may get some pulmonary edema. That's going to be dependent on how long they're on it. Etydomate, you don't use in kids, and you can get myoclonic and tonic movements. So if you do use this, you need to use some sort of muscle paralyzer, like succinylcholine or like uranium, things like that. Okay, gases. Gases, think about gases, fast. Very fast. Nitrous oxide is always in a blue cylinder. Blue cylinder. You see a blue cylinder at the hospital, it's nitrous oxide. Please don't confuse nitrous oxide, which is N2O, with nitric oxide, which is NO. Not the same thing. Not the same thing. This is a paracrine signaler in your body that causes vasodilation. You don't want to breathe a ton of this. That's what nitrous oxide is. Used mainly for dental surgeries, unless you're Haley and her family doesn't work on them or whatever. Halophane's not used anymore because of halophane hepatitis. So this one, not used anymore. These are the three that are used. The one that is the most safe is this one. Sevoflurane, that's one that's used the most. So you have with these, you have risk of laryngospasm, emesis, aspiration of gastric contents. That's why you don't keep them on the gas for very long. So this is going to be time dependent. And again, malignant hyperthermia will be induced in susceptible individuals. History will tell you if someone's had this before. Again, what's the antidote? Dantrolene. I think the trade name is Dantrium. Does that ring a bell to anyone? You seen that in the hospital? Dantrium. Okay, next clinical, ask your preceptor about Dantrium. That's your mission. Make a note to yourself. Dear preceptor, what is Dantrium? Because that's important. Okay, and then the rest is just boilerplate about using these with kids. Tend to prefer the gases because they're fear of needles. Nitrous oxide, don't use nitrous oxide in people with pre-existing bowel conditions. Increased mental air pressure. So if they have a sinus infection or sore throat, they have increased mental air pressure. don't use it. Pneumothorax, pneumoperitoneum, pneumocephalus, intraocular gas, or venous air embolism, contraindication, don't use it. And then just a word about your post-op. If you're intubating people, you'll usually use an opioid. You'll usually use fentanyl. Morphine, if you use morphine, remember it can cause hypotension because of histamine release. Meperidine. Meperidine makes a metabolite called normeperidine. Normeperidine, if it builds up in your body, it'll cause seizures. So meperidine, you have to make sure that you dose this according to renal function. So your job as the nurse is to figure out the renal function. You get to do the renal test. All right, any questions about the generals? Very good. And now for something completely different. Oh. Let's talk about opioids. Oh, I lost track of time. I'm sorry. Yes, let's have a break. Absolutely. The mind can only absorb what the seat can endure. Yep. In fact, you might see one of the dosage calculations on your homework on the final. Guys need to know how to do those.
Dr. B,
Yes.
you said the final's worth 100 points?
Yeah.
Okay. All right. Thank you.
Why, do you want it worth more?
No.
No? Okay.
Just wondering.
Yeah. Is that okay? Do you have a computer? You can, okay. Because that way you do it, you get your score right away, and you don't have to wait for it to be graded. You'll just know right away how you did. Oh, and for our shindig Wednesday, we're going to provide probably buffalo wings. And then my wife will probably make something else, knowing her. You guys bring like some chips, or if you want to make a dessert, make some brownies or whatever. We would bring whatever, just maybe try to coordinate so we don't have 15 salads. Try to coordinate with each other. The weather should be nicer, so we'll hopefully be able to be outside, sit on the lawn, and yeah, after. So the final is only 50 questions. You guys will be done in an hour, and then we'll just toddle on over and enjoy the evening. Is that your first test for you guys for finals week? No? Okay. Which one did you have today? 2? Good gravy. So needless to say, you guys are pretty burned out. Let's not. Is that a new dance move? I thought soccer was your thing. Oh, it was cold today, wasn't it? And it's supposed to be colder tomorrow. 54 and sunny, and it's going to be 30 in the morning. I'm ready for some 70-degree weather. Okay. Here we go, here we go, here we go. So, opioids work on opioid receptors. Your body makes endogenous opioid molecules. These tend to be peptides. They include things like endorphin, enkephalin, beta-lipotropin, things like that. So to give you an idea of how these work, let's go back to our little makeshift go back to our little makeshift blackboard and come on, computer. Oh, rats. Okay, now let's go. No, you. You. All right. So you have a neuron, and this neuron is going to release neurotransmitters, and this other neuron over here, postsynaptic neuron, is going to receive it. Then over here, you have a regulatory neuron. This regulatory neuron releases gamma aminobutyric acid. Now, if this releases gamma aminobutyric acid, what's it going to do to this neuron here? Gamma aminobutyric acid is what kind of neurotransmitter? Stimulatory or inhibitory? Inhibitory. So it will inhibit this. So this neuron would normally release . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . into the synaptic cleft here, it would normally release either serotonin or it would release norepinephrine. Or it might release dopamine. But if this neuron releases GABA, gamma aminobutyric acid, that will inhibit these neurons from firing. So on the surface of these neurons, we have receptors for opioids. There is the mu receptor. There is the kappa receptor. And then there is the delta receptor. And when these are bound by opioids, now this neuron is inhibited. You don't release GABA. So norepinephrine and serotonin, these types of neurons release norepinephrine and serotonin in the parts of the brain that process pain. That includes the thalamus and also the brainstem. And also in the spinal cord. When these release their neurotransmitters in these pain modulating areas, pain levels go down. And then dopamine will be released into the reward centers, like the ventral tegmental area or the nucleus accumbens. And also the prefrontal cortex. These three areas are the reward center. When dopamine is released, you get this wonderful calming sensation. So that's essentially how opioids work. They allow these pain modulating neurons to fire. By firing where they do, they decrease pain perception and the release of dopamine, which is also negatively regulated by GABA, but which is upregulated by opioids, causes this calming sensation. Even it can lead to euphoria if you overdo it. So that's how opioids work. And with and without morphine, you can see that you get neurotransmission without morphine, but with morphine, at least the inhibitory neurotransmitter doesn't release its inhibitory payload. Now, are you going to use opioids for moderate, or rather moderate acute pain? It's usually going to be used for severe pain, moderate pain, or for chronic pain. It's also used for sedation. Opioids are used with anesthetics to sedate, and they work with the anesthetics to help sedate the patient. They reduce bowel motility because you have opioid receptors also in the GI tract. If you activate opioid receptors, you decrease motility. And a couple of these opioids, through a mechanism that is not well understood, they actually act as cough suppressants as well. Hydrocodone and morphine, codeine are cough suppressants. Now you have natural, endogenous opiates, and you have exogenous opiates. For example, heroin. Heroin is an exogenous opiate that comes from the opium poppy. Have you ever seen an opium poppy? They're actually these beautiful violet flowers. They're huge. Then when the petals fall off, you get this pod. You cut the pod, you get this milky white resin. You take that milky white resin and you dry it, and you get morphine. And then if you acetylate it, you get a diacetylmorphine. Diacetylmorphine is heroin. It's very easy to make. I can show you how to make it. You know how to make it, but I won't. It's an acetylation reaction. Very easy to do. So, morphine is the prototype medication. Typically, the activity of these are usually compared to morphine. By comparing them to morphine, you are able essentially to define how potent they are. Out of all these, the most potent one on here is fentanyl, by far. Fentanyl is about 100 times per weight more potent than morphine. It's very potent. All right, so morphine, according to the US drug list, there's an oral form of morphine. However, when I contact pharmacies and say, can you get an oral form of morphine? They all tell me no. So one source says yes, one says no. One thing is for sure, oral morphine is subject to an extensive first pass effect. Remember what the first pass effect is? Way back at the beginning of the class. We talked about it, remember? No. Gets absorbed by the GI tract, goes to the liver, and the liver breaks it down. So the amount of morphine that gets into your system out of that dose is about 35%. That very good bioavailability, 35%? Nah, that sucks. So morphine is virtually always given parenterally. Fentanyl comes to the transdermal patch. It's used a lot transdermally. There's a transmucosal form, a buccal form of fentanyl you can use as well. And then IV and IM fentanyl. Meperidine, if you work in the UK, they call meperidine pethidine. Meperidine tends to be used in labor and delivery. It does cross the placenta, and it will suppress the respiratory respiration of the baby. How about you guys? I'm so done with masks. I know you guys have to wear them in the hospital and stuff like that, but I'm just so done with them. Methadone. Now, methadone doesn't cause euphoria. Methadone also has a very long half-life. So methadone is used for opiate abuse syndrome. To give methadone, you must be a federally licensed methadone center. So when a patient goes in, they leave with methadone essentially in their arm or in their veins, whatever. Doctors' offices can't distribute methadone. Only federally licensed methadone clinics can distribute methadone. Codeine is available over the counter in Canada, and it's also available over the counter in Great Britain. It's found in several different headache meds. For example, there's a tablet called Codis. It's a dissolvable aspirin with codeine. You take it for sore throat, you gargle with it, and then you swallow it. Works really well for sore throat. Codeine is also an antitussive. Why it's an antitussive is not clear. Oxycodone is only available orally. Hydromorphone comes in these particular preparations as well. So these drugs here are full agonists of the opiate receptors. Okay, so your handout handout, where'd you go? Your handout has a chart that shows you the strength of each of the opiates. Morphine is 10, and then fentanyl is 0.1. Codeine, I think, is 75 or something like that. You have that in front of you? Yeah, okay. So you can tell the strength of the different opiates. All right, big issue with opiates. They have a high risk of causing opiate dependence. If you're using opiates as directed, that's not an issue. If you're getting high on them, and the other thing about opiates, people tend to become tolerant to them because as you activate the opiate receptors, if you hyperactivate them, the signal transduction pathway on the inside now starts to wane. So you need more and more opiate agonists binding the receptor to elicit the response. So the big issue is, first of all, respiratory depression. Respiratory depression. You want to avoid any other CNS depressant. So benzos, barbiturates, alcohol, stuff like that. If you get to 12 breaths per minute, you need to hold the medication and contact the doctor. If someone is overdosed on an opiate, you administer naloxone in the form of Narcan. Narcan comes as a nasal spray. This is a demonstration mode. They come in a peeled back kit. Police carry this, firemen carry this, EMTs carry this. Please tell me you've seen this at the hospital. No? Okay. Another assignment is to ask your preceptor to show you the package with the Narcan. So you insert this, you don't prime it. If you prime it, there goes your dose. You insert this into the nostril, press, squirts, pull it out. If they don't come to, get another one, do it again. Now, let's say somebody passes out on the lawn out here because of opioid toxicity. So the triad of opioid intoxication is CORP, C-O-R-P, CORP, or corpse. C-O, coma, R, respiratory depression, P, pinpoint pupils, that's called meiosis. That's how you know if it's opioid intoxication. So use Narcan without the nostril squirt. Now they come to, they still have to go to the hospital. Not off the hook yet. Also, if they wake up, how do you situate them? Recovery position on their side, because pretty safe bet they're going to puke. So if you keep them on their back, they're going to aspirate. They're going to choke. You put them on their side, recovery position, put the hands under the head, let them recover. So Narcan comes in a dispenser just like this. So respiratory depression, that's the first biggie. 2, constipation. If they're on, say they're a cancer patient and they're on opioids and it's plugging them up, have them increase fluid and fiber intake. Remember what we did when we talked about laxatives, how you layer one laxative over the other, fiber, then Miralax and Colace, that sort of thing. Same thing with opioids. You can also use something like methyl naltrexone, a so-called Panora. The thing is with Panora is you get explosive diarrhea. So you want to stay away from those unless it's a last resort. But it's used in terminal cancer patients. We're on pretty high opiate doses. Next, orthostatic hypotension. So if the patient gets lightheaded, have them sit down, especially if they get dizzy. They need to avoid sudden changes in position. So make sure the bed's not too high. Otherwise, they may jump out of bed and down they go. Make sure when they walk that you're there with them. If they're going to walk at home, they should probably use a cane or something like that. Fourthly, urinary retention. You should try to get the patient to void the bladder every 4 hours. Keep track of input, that is input of fluid and output. Document it. Assess the bladder fullness by palpating the lower abdomen. Reason for this is that the opiate can make somebody not feel that their bladder is full. And if you feel that the bladder is full, have them go tinkle and empty the bladder. If you combine the opiates with drugs that also tend to cause urinary retention, drugs like antihistamines, tricyclic antidepressants, other types of anticholinergics, they're going to make this worse. So advise them not to use other drugs like that with the opioid. If you have a problem with nausea and vomiting, you can administer an antiemetic. We've talked about these drugs already. I'm not going to go over them. I'll just let you kind of review that on your own. And if the patient needs cough suppression, particular opioids are very good at that, particular codeine and hydrocodone. Opioids are contraindicated in people who are undergoing biliary surgery. Opioids slow down the GI tract, but they speed up the biliary tract. And if someone has a gallstone, you're going to get a colic pain. They're going to be in a heap of pain because that biliary tract is going to do the accordion thing, and that gallstone is going to be in there going, tearing up their biliary tract. So avoid giving at least morphine to people with a history of biliary colic. You can use meperidine, though. That's one of the safer ones for drugs like that. Sedation. That's the other biggie with opioids. Patients should avoid driving, operating heavy machinery, or making important decisions. Somebody calls and says, you need to sign, your lease of your house over to me. You need to do this quickly. What do? You tell them to go fly a kite. Wait until I'm done with this opiate. Overdose. They're going to need mechanical ventilation. Administer the naloxone. That will usually do the trick. People, if you give them naloxone, they tend to come around really fast. So, contraindications. Meperidine, contraindicated people with renal failure. Morphine's contraindicated for premature infants because of its respiratory depressant effects. Premature infants have a respiratory tract that's not as developed as it needs to be in the first place. So don't use morphine in premature infants. And morphine's contraindicated after biliary tract surgery. So if someone's had their gallbladder taken out, no morphine. Use opiates with tremendous caution in people who are breastfeeding and who are pregnant. Also use it in caution with people with asthma. Morphine and other opiates, because they suppress the respiratory tract, they increase CO2. That causes vasodilation of the vasculature in the head. If someone's had a head injury, what's that going to do to their head injury? That's going to increase intracranial pressure, isn't it? So they're contraindicated in people who've had a head injury. someone has an IBD, inflammatory bowel disease, and you give them an opiate, that could cause terminal ileus, where the ileum gets obstructed and plugged. That needs to be fixed surgically. That's an emergency. In men with an enlarged prostate, opiates can make it harder for them to empty their bladder. So use with caution. Meperidine should not be combined with monoamine oxidase inhibitors. Monoamine oxidase inhibitors are not used that much anymore for depression. They're making a bit of a comeback. If you use that, those two will interact. They'll cause high fever, seizures, excitation. Don't go there. If you use antihypertensives with opiates, they'll have additive effects to blood pressure. Don't use them with barbiturates, benzos, alcohol. No, no. And yeah, I think that's everything. Any questions about opioids? You guys will give a lot of opioids over your career. Just remember, know where the Narcan is. Okay, I will see you guys 7 o'clock Wednesday for the final. And then at my house afterwards for celebration of having successfully finished farm.